Japanese encephalitis. Japanese encephalitis is a mosquito-borne encephalitis caused by a flavivirus. It has been reported most frequently from the rice-growing countries of Southeast Asia and the Far East. Culex tritanuroniacus is the usual vector, and this feeds mainly on pigs as well as birds such as herons and sparrows. Humans are accidental hosts. As with all viral infection, the clinical manifestations are variable. The incubation period is 5 to 15 days. Most infections are asymptomatic. When disease arises, the onset is heralded by severe rigors, fever, headache, and malaise, which lasts for 1 to 6 days. Weight loss is prominent in the acute encephalitic stage. The fever is high, 38 to 41 degrees centigrade. Neck rigidity occurs, and neurological signs such as altered consciousness, hemiparesis, and convulsions develop. Mental deterioration occurs over a period of 3 to 4 days and culminates in coma. Mortality varies from 7 to 40% and is higher in children. Residual neurological defects such as deafness, emotional lability, and hemiparesis occur in about 70% patients who have had CNS involvement. Convalescence is prolonged. Antibody detection in serum and CSF by immunoglobulin M capture ELISA is a useful diagnostic test that can be rapidly performed for Japanese encephalitis. Vaccine containing formalin inactivated viruses derived from mouse brain are effective and available. Treatment of the condition of Japanese encephalitis is usually supportive. West Nile virus. In 1999, the West Nile virus was first recognized in the Western Hemisphere, and it had previously been reported in Africa, Asia, and parts of Europe. The outbreak in the USA produced thousands of symptomless infections. In a minority of cases, infection presents as a febrile illness with maculopapular rash, with 1% resulting in severe encephalitis. Disease severity and mortality is age related. The primary host of infection are birds. It is spread by mosquitoes and may also infect humans and horses. It can also be transmitted by blood transfusions, breastfeeding, and organ donation. Diagnosis is by genome detection in the appropriate samples or specialized serology for the detection of immunoglobulin M virus specific antibodies. Tick-borne encephalitis virus is a flavivirus that is transmitted by Exodus ticks. It occurs in an area extending from Western Europe to Japan. The tick is the main reservoir for the virus, which is transmitted when it feeds on mice and other rodents. The disease starts 4 to 28 days after a bite from an infected tick and is biphasic in 80% of the patients. Fever, malaise, headache, and fatigue are followed after a symptom free period of about 7 days, and the encephalitis ensures in the second stage. There may be associated limb paralysis, which is due to anterior horn cell involvement, mainly of the cervical region. Cranial nerve involvement also occurs. Tick-borne encephalitis virus, immunoglobulin M and immunoglobulin G antibodies are present, and the virus can be detected in the blood by PCR technique. Mortality is about 1%, but 30% patients have impairment in neurological function with persistent deficits. Now we come to the Bunya viruses, which are a large family of viruses, and most of these are also arthropod-borne viruses. Congo Crimean hemorrhagic fever is a widespread disease caused by a virus of Nairovirus genus of Bunya virus and is found mainly in Asia and Africa. The primary hosts are cattle and hares, and the vectors are hyaloma ticks. Following incubation period of 3 to 6 days, there is an influenza-like illness with fever and hemorrhagic manifestations. The mortality is 10 to 50% in Crimean Congo hemorrhagic fever. Hantavirus. Hantaviruses are enzootic viruses of wild rodents which are spread by aerosolized excreta and not by the insect vectors themselves. The most severe form of this infection is Korean hemorrhagic fever or hemorrhagic fever with renal syndrome. This condition has a mortality of 5 to 10% and is characterized by fever, shock, and hemorrhage, followed by an oliguric phase. Milder forms of disease are associated with related viruses, for example, Fumala virus, and may present as a nephropathia epidemica and acute fever with renal involvement. It is seen in Scandinavia and in other European countries in people who have been in contact with bank walls. In USA, a hantavirus transmitted by the deer mouse termed Sinombre was identified as the cause of outbreak of acute respiratory disease in adults referred to as hantavirus pulmonary syndrome. Other hantavirus types and rodent vector systems have been associated with this syndrome. Diagnosis of hantavirus infection is made by an ELISA technique for specific antibodies. Now we will discuss Rift Valley fever. Rift Valley fever is also caused by a Bunya virus. It is a acute febrile illness of livestock, sheep, goat, and camels. Rift Valley fever is found in southern and eastern Africa. The vector in East Africa is Culex papiens, and in southern Africa Aedes caballus, but can be transmitted by the bite of an infected animal. Following incubation period of 3 to 6 days, the patient has an acute febrile illness that is difficult to distinguish clinically from other viral fevers. The temperature pattern is usually biphasic. The initial febrile illness lasts 2 to 4 days and is followed by a remission and a second febrile episode. Complications are indicative of severe infection and include retinopathy, meningoencephalitis, hemorrhagic manifestations, and hepatic necrosis. Mortality approaches 50% in severe forms of illness. Treatment is supportive. Animals can be vaccinated, and that is it for Bunya viruses. Thanks for